Welcome, everyone. Thank you all so much for being here today. I'm Jamie. I am with Metro Council, and we're so excited that you're here for our webinar today. So, a little bit about Metro Council. We are the Metropolitan Council of Community Mental Health Centers. We represent 9 different organizations throughout the Kansas City Metro, and that includes University Health Behavioral Health, Swope Health, Beacon Mental Health, Comprehensive Rural Mental Health, Rediscover Mental Health, Wyandotte Behavioral Network, Johnson County Mental Health Center, and then Mental Health America of the Heartland. So between all of our organizations, we are so excited you are here. We do webinars like this on the second and fourth Thursday of every month. We make them free so that everyone can learn about mental health. And so they're always free on the second and the fourth Thursday of the month from 12 to 1. So hopefully, if you have not joined us before, you will start joining us. And if you've joined us before, welcome back. So a couple of things to note about the webinar. So this is Zoom webinar. So that really what that means is you'll be able to see the presenter and me, but not yourself. And you'll be able to communicate though through the Q&A and the chat box. So you can still communicate, you just can't see yourself and we can't see you. But you'll still be able to get all the wonderful information. And then at the end, I will give you a web address with a password, and then you'll be able to get your certificate of attendance at the end of the webinar today. So, so you'll still get a certificate of attendance, and you'll still be able to see this great webinar. Little disclaimer, so the views and opinions presented are those of the speaker. They don't necessarily represent the opinions of Metro Council. So a couple quick other announcements. I'm going to stop my share. So we are so excited because so as part of Metro Council, we have the Mental Health KC Conference or Mental Health Kansas City Conference every year. And we are so excited because the wait is over. Registration is finally open and we are so excited to have that open. I just put it in the chat. You are one of the very first to hear. So it is May 29th and 30th at Johnson County Community College. And we are really excited to be able to have it every year. And so yeah, one thing I should note, couple little changes this year. So we've always been able to offer certificate of attendance. We will be able to offer that again for the Mental Health KC conference. But this year we are also able to offer real CEUs. So the cost for the regular certificate of attendance is still the same. I know prices have gone up for everything, but not our conference. We are keeping it the same. So because we want to make it affordable for all of you. So it is still only $50 for about a little over 8 contact hours, which is really exciting. And that also includes lunch and snacks. So really great deal. And 2 professional keynote speakers and 72 breakout sessions. So a lot of options for people. But then we are also offering, as I said, real CEUs. Those are $20 extra. But for those of you that need it for licensure, $20 is a really, really good deal for the number of real CEUs you'll be getting. So join us for the Mental Health KC conference. Also new this year, we are having poster presentations. So, and by being a poster presenter, you will get half off. So that means $25 or and the CEs are still $20 because that's how much it's costing us. So we're trying to make it as affordable as possible. But as I said, if you would like to be a poster presenter, we are accepting posters. Currently, it is open until April 15th. I just put it in the chat. So you will be able to, if you would like to get to be a poster presenter, you are welcome to be. So I see that Deborah has asked about the speaker presenter topics. Yes, they have been published. Everything is on the registration site. So you can see all of the breakouts, all of the speakers, the keynotes, everything is on our registration site for the Mental Health KC conference. So thank you for asking, Deborah. And with that, I am so excited to introduce Jennifer. So Jennifer Kaseff is a licensed professional counselor and clinical supervisor in the state of Missouri and is a nationally certified counselor. And Jennifer received her bachelor's degree in psychology from Indiana University, go Hoosiers, and received her master's degree in clinical mental health counseling from Roosevelt University in Chicago. Jennifer currently works with children, adolescents, and families as an outpatient therapist at University Health, KC, Lakewood Counseling. She has extensive experience providing evidence-based treatments within the individual therapy and family therapy settings. And Jennifer has been trained as a in cognitive behavioral therapy, so CBT, trauma-focused cognitive behavioral therapy, acceptance and commitment therapy, and several parent management training modalities. And Jennifer provides supervision of master's level interns and provisionally licensed counselors. So with that, I am so excited to introduce Jennifer and take it away.
Thank you, Jamie, for that kind introduction. Hi, everybody. Like Jamie said, I'm Jennifer Kaseff. I am a child and adolescent therapist at University Health Lakewood Counseling, and I'll be giving my presentation today. I'm going to, Jamie, is my screen isn't shared, is it? Okay, let me go ahead and share my screen with everybody. Am I good to go? Awesome. Okay, great. So today we're going to be talking about different considerations when working with youth. The title, Document or Didn't Happen. So some considerations that we'll talk about will be pretty clinician focused. Some will be more for the general public, more for parent, teacher, other caregiver focused. So I'll kind of talk about as we go through what is more specific for a clinician and more ethical considerations when documenting or when working with kids and teens, and then what can be helpful for parents and parents and teachers when working with our youth within the therapy space or outside of it. Let's go ahead and get started. Okay, so just to start off with a little disclaimer, so the content of this presentation is intended solely to provide a general overview of considerations when working with youth, and this should not be substituted for any legal or ethical guidance at this time. So the objectives of the webinar today is to define child and adolescent therapy, what that looks like, discuss the considerations when involving caregivers within treatment, discuss the importance of documentation, and also discuss the importance of their involvement. So within that setting as well. So let's start at the basics. What is child and adolescent therapy? So what that is considered is oftentimes individual therapy working with people under the age of 18. Children and adolescents are referred to individual therapy for a number of reasons. For example, anxiety, depression, trauma, school avoidance, inattention, behavioral concerns, either at home or at school. Of course, these are just a couple of common examples. This does not complete the list at all. Working and then within child and adolescent therapy, we're working with both children and adolescents as their identified client or the identified patient along with their caregiver. So sometimes that's the parents, sometimes that's grandparents, sometimes that's aunts and uncles, sometimes that's a foster parent. It can look like a number of things. Throughout my presentation, I'll use the terms interchangeably. I'll use caregivers, I'll use guardians, I'll use parents, but I do often use them interchangeably. So what does evidence-based therapy look like in the context of working with youth? So I'm talking about evidence-based therapy and in the context of my work. So my primary modality that I use is CBT, so cognitive behavioral therapy. Typically, CBT is a short-term treatment model. Oftentimes, it's between 6 and 20 sessions that really focuses on teaching youth and their parents specific skills to manage, kind of to regulate and manage emotions, as well as identifying the links between our mood, our thoughts, and our behaviors, our activities, or maybe the choices that we make. Oftentimes we'll talk about challenging negative thoughts, increasing enjoyable activities, and building skills to maintain relationships. Another aspect of evidence-based therapy that's within child and adolescent therapy is parent management training. So we'll talk about that a little bit later in the presentation, but oftentimes that looks like meeting with parents without the child present, giving them tools and skills on how to modify certain behaviors that are undesirable, and helping encourage and motivate their kiddos to behave in a desirable way. Other aspects of that could look like problem solving or social skills training and behavioral therapy. So giving education, giving exposure, behavior activation, and modeling those skills and behaviors as well. Okay, so first and foremost, to talk in terms of differences between child therapy or working with youth and working with adults is caregiver involvement. And that can look like, and like I had talked about, a number of things, a number of people, parents, grandparents, aunts, uncles, the primary caretaker of a child. So there's lots of different elements involved in caregiver involvement with when working with youth. First and foremost, consent to treatment, communication of recent events, symptoms, and/or safety concerns, in having them engage in sessions, engagement in the sessions, and then parent management training for behavior modification, as we just talked briefly about. And we're going to kind of break these down and see what this looks like. It also, there's a lot of research that shows that there's a correlation between parent involvement and parent engagement in the therapy process and better treatment outcomes as well. So first and foremost, before therapy or services can even get started, we want to address consent to treatment. So all guardians with legal rights to the child are given the opportunity to consent to treatment if parents or guardians are not married. And this is the guidelines within Missouri. Other states may have different laws or guidelines. This is the guidelines that we follow within my practice and within my clinic that's located in Missouri. So with that being said, treatment cannot proceed if consent is not obtained by at least one guardian. And all guardians, like I said, are given that opportunity to consent. Obtaining, and another consideration with that is obtaining consent or collaborating in treatment with an uninvolved or unengaged parent. So, with that being the case, oops, went too far there. If that is the case, making sure that we're making attempts to reach out to, a secondary parent or an unengaged parent, just to make sure that we are doing our due diligence and to reach out to that parent or guardian, making sure that we're giving them the opportunity to consent to treatment, and other opportunities to be involved along the way. Okay, I gave you a sneak preview, but document is key. So the next really important aspect throughout all of this, especially for our providers and our clinicians out there, is documentation is key. So if it's not documented, it did not happen. So thinking about in terms of consent for treatment, so making sure that within the documentation, it's documented that parent or guardian is consenting to services, and that we're attempting to reach out to gain consent from another guardian if they're not living in the same household. It's very important to also document information that's happening within session and outside of session as well, such as phone calls, emails, let's say conversations. Oftentimes, at least from personal experience in my clinic, we have a waiting room that's for therapy, but we also have psychiatric services as well. So oftentimes, sometimes I'll run into a parent or a guardian in the lobby. We may have a conversation that's needs to be documented if there's important information shared or whatnot. So all those things, it's important that those are documented. There's clinical, ethical, and legal considerations for all of those things in terms of documentation. From a clinical standpoint, it's important to document our progress, right? What's going well, what's maybe not going so well. Is the child responding well to treatment? What modalities or interventions are working, what's not so working, are they making efforts outside of session, are they practicing their skills, what are they doing, if or lack thereof. So making sure from a clinical perspective we're documenting that progress. From an ethical perspective, making sure that it's documented that we are doing our due diligence to reach out to both guardians if that's the case for the family dynamic, making sure that we're also contacting parents or guardians in instances of updating treatment goals or any safety concerns of that matter. And that's kind of what leads us into our legal considerations as well. So making sure that it's clearly that things are documented when we attempt to contact parents if there's ever any safety concerns or consent. So parents have legal rights to consenting to treatment and the legal rights to information regarding their child's safety. So making sure that all that is documented in there as well. Documentation is also important when talking about the privacy for the patient or for the client. So it does get a little bit sticky with children because they are underage, they are minors. Parents do have legal rights to all of their documentation, and privacy is kind of it's an interesting word because kids are, privacy is preferred in therapy. However, there isn't a lot of legal leeway oftentimes for that. Parents do have legal rights to the documentation. So just being mindful of that when documenting in a certain way that's vague enough, that's still, specific enough where it's still protecting specific topics that maybe a patient is talking about or client is talking about in session. Okay, got a couple examples to throw in there. Some possible scenarios that could come up in child therapy, just to get everybody's brain working a little bit. So here's the first example. Ashley is a 7-year-old female presenting to therapy with her mother due to recent reports of Ashley being bullied at school. Ashley's parents are divorced, and Ashley's father is currently incarcerated with a release date in 3 months. Ashley's mother consented to therapy services at the initial visit. So thinking about how might a provider handle the situation, this is more for our clinicians and providers out there. What are some ways that documentation would really play a role here? So there's lots of options here. There's lots of things that we can do. From my perspective, how I would, tackle this is, being very upfront and honest with the family and saying, hey, first I would want to know, does Ashley's father have legal rights to the child to consent for treatment? And if they say, tell me no, I would want documentation on their end to reflect that. So what that usually looks like is some type of custody paperwork to identify Ashley's mother being having sole legal custody. If they say no, we have joint custody. However, we don't have any contact with Ashley's father right now since he's incarcerated. I would explain to them that we will, I will be reaching out to Ashley's father once he is released to obtain his consent at that time. So I do really like to, at least within my work and in my style, I find it to be best practice to be very upfront with that information so we don't get 3 months down the line, something like this, Ashley's father is released, and that there's not any surprises. So they know, upfront what it's going to be, what's going to happen. And then in terms of the documentation, how that plays a role, making sure that those conversations are documented very explicitly in, the initial intake paperwork or somewhere with that in that first note that was explained to them, and following up with that they indicated understanding so that, all that's in there if it ever came back up again. Also, documenting the fact that, Ashley's father is currently incarcerated and will be following up for consent to treatment, following his release. Okay, moving right along. So another aspect when working with youth and therapy, another consideration is conflicting co-parents. So
Jennifer,
yes.
Somebody had a quick question.
They said, sorry, yes, I'm not looking at the chat. I apologize.
You're good. That's what I'm doing. No worries.
Thank you. Okay.
So would you not see the client until father consents then? And even if he even if he's incarcerated?
That is a really good question. So how, and I would, everybody's licensed and everybody's do ethical codes read a little bit differently. So first and foremost, I would advise people to, talk to their liability insurance, look at their ethical codes to help guide in that situation. I would continue and just let them know, hey, we will, at the time where he is released, that's when we would go ahead and ask for consent. Since when folks are incarcerated, we don't have a way to really reach out and contact them to obtain that consent at that time, unless there's a way that we can set it up to gain that consent at the beginning. We would wait to obtain that consent from when they were released. Great question. And again, just to be clear, that's how I would handle it. That is not necessarily legal or ethical guidance in that way. Great question. I'll be better at monitoring the chat. I apologize, everybody. Okay. Moving right along here. So conflicting co-parents. So oftentimes we have conflicting co-parents when parents are separated or divorced, not living in the same households, when there's two separate households, sometimes with two different household rules or expectations where parents don't necessarily see eye to eye, or there's conflicting opinions about certain things. So having to navigate that within the therapy space can definitely be a nuanced skill for therapy providers when working with youth. So in those situations when they pop up, so it's important that we're communicating with all caregivers in a consistent and direct manner. When having those discussions on clinical matters or disclosing important to all caregivers. So sometimes what that looks like, if parent A is, oftentimes brings, the child to therapy. So let's say there's some safety information or some important information that's disclosed during that session. It's important that, of course, we're pulling the parent that's present with them at the time of the session into the session. However, let's say that there's parent B does not live in the same household. It's important that we're making a phone call either during the session or afterwards to notify them of that information as well. And sometimes we'll get inconsistent information between parents, or, hey, this happens at parent A's house, but we're not seeing these behaviors at parent B's house. So making sure that as the provider, being that neutral party between the caregivers, oftentimes things can get a little contentious between parents if they're separated or divorced or have never been married sometimes. And so things can just get contentious, especially if there's a difference of opinions. So making sure that, we're just, as the provider, being that neutral party between the caregivers, and instead of, maybe taking a side or taking a stance one way or the other, just remaining very neutral, and also remaining within scope of practice and redirecting when outside. Oftentimes, parents will seek out different recommendations for custody or recommendations for various other things that are more legal related or outside of the scope of practice. So just knowing what your scope of practice is, what your ethical codes read, and redirecting when it's outside of that. And like I mentioned before, those conflicting household rules. So trying to navigate that figuring out that, how can we, as a cohesive, unit, try to have consistent household rules or expectations to help guide the child as well. Okay. Okay. All right. We have another example here that could pop up when working with youth. So Jimmy is an 8-year-old male coming to therapy because he is not wanting to attend school and is having anger outbursts daily before school. His father is very motivated for Jimmy to begin therapy and is present during the initial appointment to begin services. Jimmy's father has stated Jimmy's mother does not want Jimmy to be in therapy because it's for crazy people. Jimmy's parents were never married. However, they are no longer in a relationship. Jimmy's father stated she's not really in Jimmy's life anymore, and she never calls him. So what do we do in this situation? How do we handle it? And then how do we document it? So similar to the last case, first and foremost, we want to ask about what legal rights Jimmy's mother would have in this situation. So if Jimmy's mother does not have any legal rights, I would ask for the paperwork to reflect that Jimmy's father has full custody. If we have that, great. We can move on since Jimmy's mother doesn't have any legal rights. If they do not have custody paperwork, which sometimes pops up, or there is custody paperwork that reflects joint custody or shared custody, I will, let them know that, hey, I'm going to reach out to mom, let her know that we're beginning therapy services, giving her the opportunity to consent for those services. And sometimes, especially parents that are a little bit more hesitant about their kids starting therapy, there is a lot of misconceptions about therapy, especially working with kiddos in therapy. So just giving a little bit of psychoeducation and first normalizing that, hey, yeah, this is kind of unknown and this is kind of scary. And then just giving that psycho ed about what we're going to work on, or kind of where we're at. And also that informed consent piece of like, this is what we're going to do. This is what we're thinking. Here are the treatment goals that we're thinking about, and trying to involve in treatment for that engagement, for that involvement. Okay, moving right along. So we talked about this briefly on a previous slide, but confidentiality with caregivers. So we previously talked about progress notes or those therapy notes. So right to review versus recommending to review. So parents or legal guardians do have the right to view all therapy notes or any documentation, at least within the context of my clinic and where I practice. However, it's something that I like to share within my informed consent, and when I do my initial session with patients and their families, is that we do advise them not necessarily to review the documentation and the paperwork, just to protect the privacy of the child and throughout their therapeutic process. Of course, this does not include limits of confidentiality. So anything that's putting the child at risk of anything that would put them be unsafe, others unsafe, or somebody there's any safety concerns about them. As you all know, we are all therapists are all mandated reporters, so we are legally obligated to report any suspected abuse or neglect. And so making sure that it's very clear that here are the times that we will break confidentiality due to those limits of confidentiality. Here are the times where we would not. Oftentimes, I will give my patients the option to say, hey, do you want to tell this to your parent? Do you want me to tell it with your parent? But it needs to be disclosed. And then we also talk about that there's times where it's helpful that parents may want to know something that's going on. If there's a certain concern or certain symptoms that are going on, or maybe a certain interpersonal distress that's happening, and that I always give my my patients the option of, hey, do you want to bring, your parent in or your caregiver in and loop them into this, so they just have some knowledge about the situation. And at that point, it's not legally required to tell parents, so giving them a little bit of that control, I find to be helpful. The other aspect with confidentiality with caregivers is I hear oftentimes from parents or caregivers, did they talk about X? Did they talk about this thing that happened at school? Did they talk about how they're not getting their homework turned in? Did they talk about that they're having a hard time falling asleep? So a lot of these things can be tricky to navigate at some point because oftentimes parents or caregivers do have that, the best intention that they want them to be using these therapy services, and to the best of their ability. They want them to be talking about certain topics. However, in terms of confidentiality, we can't necessarily disclose, all the things or we don't recommend disclosing all the things that they had talked about in session. So oftentimes I will redirect and say, hey, I would follow up with your child and see if that's something that they had talked about today, or that they feel comfortable sharing. All right, so another aspect of treatment when working with youth is non-custodial caregivers. So typically this involves any adults in the child's life that does not have custodial rights. So grandparents, step-parents, aunts and uncles, neighbor, those adults in their life that are very involved, know what's going on, maybe transporting, that can give helpful insight and feedback into the therapy process. So parents and legal guardians must sign a release of information for those adults, including step parents. So how the law reads, at least in the state of Missouri, is that step parents are not considered legal guardians, even if they're married to a biological parent or a legal guardian. So we do have to obtain a release of information for those step parents. And then there's lots of benefits of getting a release of information signed for a non-custodial caregiver. Maybe that it's the grandparent that's often transporting the child to therapy. So having the ability to check in, have them involved. Hey, what's going, how has the week been? What's going on? If we don't have that release of information signed, we really can't, we don't have permission to have even just a conversation about how the week's been with those adults.
Jennifer, we have a couple of questions. So one of them is, if a parent who has legal rights over a child you're seeing wants you to tell them what their child talks about in therapy, services, etc., do you have to tell them, or do we still defer to confidentiality agreements and ethics?
That's a good question. So ethically, I would refer them back and just say, hey, I would really, I want to protect the confidentiality of your child. I may remind them that they do have access to those notes. Legally they have access to the notes. They don't necessarily have access to all the nitty gritty details of the information that is shared. If they press on it again, I would likely seek guidance, specifically what they're wanting and why they're wanting that information. I think that would help me make a decision. I also tend to remind parents when if they feel a little anxious about, what's my kid talking about, I often remind them about limits of confidentiality too, that, hey, remember, here are the times that I will be telling you if they disclose something like this. And oftentimes that will ease the anxiety of the parent. Hopefully that answers the question.
And then we have one more question. What
Sure.
if the step parents do have legal guardianship, like they legally adopted their stepchild?
That is a great question. So in that case, we wouldn't need the release of information side. We would just need that adoption paperwork that would serve as like custody paperwork. So if they have those legal guardianship, then they would be considered a legal guardian instead of just a step parent. Great questions. Okay. Moving right along here. So another consideration here is caregiver engagement and treatment. So caregiver engagement and treatment looks a little bit different than caregiver involvement. So involvement is really that, we're having them involved. So we're getting the consent, we're checking in with parents, we're letting them know if there's ever, any safety concerns. Engagement is actually having them engaged and present for sessions. And of course, this can look different depending on the age, the diagnosis, the treatment goals, and the family dynamics. So, typically the bare minimum is checking in with the caregiver at the end of session, oftentimes reviewing the skills learned during or at the end of session so that parents or caregivers are able to reinforce or practice those skills outside of session. I oftentimes tell my patients or tell families that, we're only meeting for 45 minutes once a week, maybe. So that's where we learn the tools. However, if we're wanting to really get good at something, we got to practice it outside of there. So oftentimes parents, depending on the age and the diagnosis of the patient, attending those sessions with the child to learn the skills and modeling. Oftentimes we'll see this happen a lot with younger children, where it's really, really helpful to have the parents interact with the child in the session. And so maybe we're playing a game and maybe we can use our skills right there and then, and parent can see that and also model the skills for the child as we're doing it or as we're playing, so that they can go home and recreate that in their home or maybe, at school as well. And then caregiver engagement can also look like those parent or caregiver sessions. So parent management training, which we'll talk a little bit more in just a minute. So here is, so another aspect is just for parents specifically, so modeling some coping skills. I'm going to go through them slightly quickly. I want to be mindful a little bit here of time, so I'll go through them a little fast. But some helpful skills that oftentimes we will learn in therapy sessions that oftentimes I will encourage parents or caregivers to then go and model and recreate in the home is a couple of these. So creating a list of relaxing or pleasurable activities. So those coping skills, use those ideas based upon your knowledge of patients' interests. So depending on what they like, oftentimes I'll give my patients or my clients a whole laundry list of relaxing or pleasurable activities, and we'll pick a few. Sometimes we'll make a coping box or a coping card. I have a little pizza on there. My personal favorite is to make a coping pizza, because who doesn't like pizza? We'll take, sometimes like an outline of like a wheel and make it, decorate it into a pizza. So I find that the more exciting and the more engaging the activity is, the more likely, especially younger ones, kids, that are going to use those skills outside of the session. All right. Another skill that can feel fairly basic, but going back to basics is often very helpful, is diaphragmatic breathing. So diaphragmatic breathing, or belly breathing, kind of involves engaging the full stomach, abdominal muscles, and diaphragm when taking deep breaths. So during breathing, a person consciously engages their diaphragm in order to take deeper breaths. So obviously everybody breathes, and it's pretty an unconscious thing that we all do to survive. But taking diaphragmatic breathing, it does help us take a step back and really focus on our breathing to help us regulate our emotions and grounding, and help us calm down a bit. So just like building endurance in sports or other things, maybe learning a language, breathing must be practiced just like any other skill that we're learning. It really is not effective to wait until the anxiety, distress, or upset rises and to try to start, okay, what did my therapist say, or what am I supposed to do? This is something that's really, really helpful to practice on a daily basis when we're calm. And some of my families that I work with sometimes get a little confused by that. It's like, well, why would we do this if we're calm? Because the more we can do when we're calm, the more that it builds into our muscle memory, and the more likely it is that we're going to use it when we're not so calm. So planning a specific time each day. Bedtime is a great time. It's time that we're trying to relax anyways, to practice these skills. Setting just a brief period of time. It can be 1 to 3 minutes. It does not have to be a long period of time. Encouraging the caregivers. This is where we want to bring in our caregiver involvement to practice with the child, especially if they're in the younger side, but all ages. I think it's helpful to have parents using these skills as well. There are also several apps that older kids and teens may enjoy to help practice these skills. So some examples of diaphragmatic breathing, just again, to be creative, so we can smell the flowers. We can blow on the candle, blow on hot chocolate. That's one of my personal favorite. Balloon breathing, so just again, filling our belly up like a balloon, blowing bubbles, and blowing on a pinwheel. So sometimes it's helpful to actually have the pinwheel to see it moving, but those are just a couple of, again, just creative examples to help, especially younger kids, feel really engaged and actually practice and use these skills. Okay, so another aspect of parent engagement within therapy is parent management training. So I've kind of mentioned this kind of throughout. I'm going to give you a little bit more details of what this means and what this looks like. So parent management training is an evidence-based treatment or modality to help parents manage and modify undesirable behaviors. And it provides caregivers with tools to help manage and modify those behaviors. Oftentimes we're working on implementing positive reinforcement strategies, and also working with the parents for them to utilize those emotion regulation skills to model at home. So I oftentimes will tell parents and caregivers that, kids are like sponges, is that they model and they soak up everything that they see. So the more often that our parents or caregivers are able to utilize these skills, the more likely that we're going to see our kiddos use them as well. Some examples of Some modalities for parent management training is Love and Logic, the Casing method, and Defiant Children. If you're interested, I definitely encourage you to do some research in these areas. There's definitely lots of wonderful skills and tools. We could do a whole nother webinar about all three of these things. We don't have the time for those today, but very, very wonderful and helpful tools. Okay. So something that comes up oftentimes with most clinicians, however, I see happen oftentimes with a lot of child providers, and especially in a consideration in child therapy, more times than with adult providers, is hotline reports and mandated reporting. So as most of us know, all therapists are mandated reporters. Myself in the state of Missouri, and so we have children disclosing potential information to us. So, determining how do we navigate that? How do we document that? How do we handle that? Because it's not just the information being shared with us, but how do we also then navigate it with the parents? So first determining, is this information that fits into the guidelines that needs to be reported? So sometimes it's important to consult on that because there's a lot of gray, as we all know. So consulting, and oftentimes that means consulting with the hotline. I've definitely done that before. It's figuring out, okay, a hypothetical situation, would this be considered a report? Would it not be? And then step two is then if we do report information, how do we navigate this? Do we share the information with the parent? Do we not share the information with the parent or caregiver? Are we legally obligated to? Are we not? It all depends, right? So first and foremost, I encourage everybody to, consult with their ethical guidelines and their liability insurance if they're wanting some guidance in that way. For me personally, it's not so cut and dry. I'm a big believer in consultation and consulting about, how to move forward and documenting that consultation as well. Whether it's with the actual, hotline intake coordinator or whether it's with a supervisor or a colleague, making sure that we're consulting and weighing the pros and cons. My personal best practice for me is, unless there's a significant safety concern about why I would not share the information with a parent or caregiver, I do like to let the parent and caregivers know that I am making a hotline report, whether it involves them as the parent or caregiver or another adult. And because I try to minimize the stigma around making hotline reports and mandated reporting, because, thinking about why do we do this? It's really to connect. It's one, to keep kids safe, but also to connect families with guidance and resources to help keep kids safe. Unless there's, like I said, a significant fear or safety concern as to why I would not share that information, I would go ahead and let them know. And then again, following up with that documentation aspect of it, how do we document that? So making sure that if information is disclosed to us as providers, that would be reported to the hotline, that we follow up with, here's the information that patient disclosed, blah, 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 whatever that said. Information will be reported to the hotline, or was reported to the hotline during session, getting the name of the person that took the information. Oftentimes they have a ID number, I like to include that as well, just to cover all bases. If I do end up disclosing the information that a hotline report was made to the parent or caregiver, I will, I'll put that in my documentation as well, just so, ethically, it's all there. And again, documenting that parent or caregiver indicates understanding that a hotline report was made. Okay. Another example that may pop up working with youth. So Corey is a 10-year-old male presenting to treatment due to recent behavioral changes. Corey's parents are divorced, and both parents consented to therapy at the beginning of treatment. Corey's mother during the first appointment, and Corey's father in a phone call immediately after the appointment. After a few sessions, Corey disclosed that his father has been physically abusive towards him several times over the last few months. As the provider, you report this information to the Missouri hotline, and the information was found to be substantiated, you receive an angry phone call from Corey's father insisting he never provided consent for treatment and he plans to sue you and your agency. Okay. Get a sip of water for that one. So again, this is a wonderful example why documentation is so important. So let's just kind of break it down here. So starting with, when Corey comes in with his parents to begin treatment, so having the documentation about Corey's mother consenting to treatment during that first appointment, and then documenting that phone call immediately after, with Corey's father providing consent for treatment. So having all of that in there, because if, like we talked about before, if it's not documented, it didn't happen. So if for some reason that documentation is not in the chart or within the notes, then it's like it didn't happen. And Corey's father in theory could be right that he's saying that he didn't get consent. There's no proof of it. So that's in theory true. So making sure that documentation is there. I also, receiving a phone call like this would make sure that, depending on the nature of the phone call and what's being said, sometimes I will document word for word what the parent is saying or the caregiver is saying in the phone call, just to make sure that that's adequately documented. I would explain to him about being a mandated reporter, which is, of course, also documented within informed consent, letting them know up ahead of time, which I don't think I had mentioned that much, but going back to just, letting the family know up ahead of time, I am a mandated reporter. These are the times that I would have to make to break confidentiality to make a report. And of course, that's important to have documented within the documentation as well, that's disclosed typically during the first session. So reminding Corey's father of that, and, depending on how escalated it gets, making sure that, we may have to consult liability insurances, consult if people have a legal department, making sure other people, especially if there's being threatened of a lawsuit, consulting with, a legal team or liability of insurance, and know the best way to proceed in that way. And in a situation like this is where it really, really shows how important documentation is to getting consent, for informed consent, letting them know here, that this is who I am, I'm a mandated reporter, this is the times where I'm going to break confidentiality, so that they know ahead of time, and then covering ourselves and protecting ourselves as providers to from potential lawsuits in that way. Okay. So other considerations when working with youth. So managing a client's expectation versus a caregiver's expectations. We'll see this oftentimes where maybe a client will come in saying that they want to work on increasing their focus, and maybe a caregiver wants to come in and their goal is that they want to work on the child improving their grades or something. So managing what the child is looking for versus what the caregiver is looking for, sort of what it looks like, different treatment goals or whatnot. Sometimes clients, kids and caregivers can come in terms of expectations of different levels of motivation. Oftentimes we'll see that parents are very, very motivated for their child to start therapy. Their child, not so much. They feel like things are going very well. So the perspective can be very different, or vice versa. Sometimes a child will come in and say, hey, I'm feeling very worried, or I'm feeling very tired. I'm feeling, my mood is low. I really want to work on these things. And the parents say, oh, I don't really see anything wrong. I don't see something going on. So making sure that we're coming together and talking about this collectively to manage both the expectations of the client and of the caregiver as well. And then another consideration, which we've sort of talked about throughout, is using age-appropriate language and examples when providing psychoeducation or teaching skills. So I mentioned that a little bit when we adapt and we get creative when working on some of our coping skills or some of our diaphragmatic breathing, just making it fun. The more fun we can make it and the more exciting it is, the more it's relatable, especially to younger kiddos, the more we're going to get that engagement, and more likely we're going to see results. And also using age-appropriate language. If we're talking about, maybe we're talking about effective communication and using language about communication in a workplace, probably not going to work that well for a 10-year-old. So making sure that we're using examples and we're using appropriate language that would be relatable for, a child of that age. All right, we got one final example here. So Olivia is a 15-year-old female presenting to treatment with her parents. Olivia has had recent behavioral changes, such as lying to her parents, sneaking out, drinking, and skipping school. Olivia used to be a straight-A student, but is now failing most of her classes. When discussing motivation to treatment, Olivia's parents were very excited for Olivia to begin. Olivia rated her motivation to treatment as a 1 out of 10, stating, "There's nothing I want to change or work on. My parents are making me do this." Okay, so how would somebody handle this? So something that I personally talk a lot about with my patients, and I've seen this time and time again, especially with teenagers, is that treatment is most effective for youth when they're willing to participate and have insight into those problem areas and have the motivation to make those changes. And so I always tell my kids and my teens that, hey, therapy is optional. I'm not here to force you to do this, because oftentimes if kids do feel forced to engage in services, that oftentimes they'll put in more of a negative connotation around therapy, which can carry on for a long time into their adulthood. It's very important to me in my work that therapy is a positive experience, even if later on in life, let's say kids, they graduate, they discharge from therapy, and they may not remember the specific skills they learned later on in life, but they remember having a positive experience or it being fun. The more likely that they will be able to return to therapy, as an adult and as they're older, to receive those services, versus if they feel like there was something that was forced upon them, or they didn't really like it, didn't really need it, that may not necessarily be the case. So in this situation, I would talk with the family, with both the kid and the parents about, hey, let's weigh the pros and cons. Like, okay, motivation is 1 to 10. Maybe I might say, like, let's try out a couple of sessions just to see, because sometimes the lack of motivation really just comes from, I don't know what this is. I don't know anything about it. It's unknown. And there's some anxiety around it. So just trying to figure out where that lack of motivation is coming from, and going and handling it from there. And then in terms of, for our clinicians out there, how to document this, making sure that we are documenting that the low motivation to change, and talking about that, any following sessions, so that we're documenting any progress or lack thereof from a clinical perspective. Okay. All right. Any other questions? I'm glad people asked throughout, but
And Jennifer, Jason had said that during when you were talking about the example, motivational interviewing focused on finding things that are important to Olivia.
yes, absolutely. Basically, I pretty much explained motivational interviewing, but that's, yes, to put a label on it, yes, definitely using motivational interviewing to help find those problem areas or to increase the motivation, for sure. Great point, Jason.
Okay, so we have a question. If one parent gives consent, but the other parent does not give consent, are you allowed to treat the child or not?
Okay, so again, with some of these legal considerations, always consult your legal team or legal department, or your malpractice insurance. However, how I would handle it, I would not move forward. If a parent explicitly says, I do not give consent, then at that point, we would not be able to proceed with services.
Okay, next question. What are your thoughts on recent current affairs and things that we should be cautious to document?
That is a great question. So being mindful about it, as we know, things are ebbing and flowing and changing, feels like on the daily basis right now. I would say stay current with what your current guidelines and considerations are at this moment. and thinking about, who can see the documentation. So, if there are things being discussed that would fall into that category with recent current affairs, just being mindful of that and document in a certain type of way where it might be a little bit more vague. So it would be harder to interpret from the naked eye per se. Great question.
Okay, what other questions do people have? You can put it in the chat, you can put it in the Q&A. We still have a little bit of time for questions. Okay. Well, I just want to thank Jennifer again. Thank you so much for your webinar. I think you did incredible and great job of really like explaining the importance of documentation, because you're so right. You don't document, like it never
Didn't
happened.
happen. Yes.
So,
Well, thank you, Jamie. Thank you to the Metro Council for having me. It's been a pleasure, and I really enjoyed being here.
So just another kind of quick reminder, registration for the 2025 Mental Health KC Conference is open. We hope that you will register and join us in May for our 2025 Mental Health KC Conference at Johnson County Community College. Also, if you are interested in being a poster presenter, we are going to have a poster session this year, and we're so excited for it. So if you or your organization has anything that you would like to present, whether it's a research project or a program that you think would be really beneficial for others to hear about, we still have our poster sessions open. So we would love for you to fill out the application. It's really easy, and hopefully you'll be able to do that. And then our last thing is our certificate of attendance. So certificate of attendance is available. Okay, and it is now up. So certificate of attendance, you just click on the link and then the password and you are good to go. So thank you all so much for joining. Come join us next month, and we hope to see you all soon. Jennifer, if you want to stick around for a couple of minutes in case people have other questions, I'll stick around as well, and hope everybody has a wonderful rest of your day. Thank you. We have a lot of thank yous. So people really enjoyed it.
Glad to hear.
Sherry, can you hear me? Hopefully, yes. Jennifer, can you hear me?
Mhm.
Okay, fantastic. Said my earbuds have drained their power, so hopefully
They're
this
all
is still
done.
working. But so Sherry, certificate of attendance is in the webinar chat. So you click on the link and then put in the password. I'm putting it in there again just in case. Sherry, hopefully that helped. Well, thank you guys again so much for joining us. Thank you again, Jennifer. And I hope everybody has a wonderful rest of your day.
Thank you
Bye,
again.
everyone.
Bye.